Hey everyone, this is Brian and Chris from the Student Physical Therapist website. Today we're going to talk about some of the differences between a sports and orthopedic residency. We've been getting a lot of questions from residency candidates on what we believe are the similarities, differences, so we're going to touch base upon those today. Chris, thanks for joining. Let's go ahead and start with the first question we're getting. What do you think the differences are between an orthopedic and sports residency?
Well, I think one of the biggest differences is probably just where the training is focused. I mean, we know that sports has a base of ortho in its background, and the focus then becomes what your patient population is. So, with the sports residency, you're going to get probably advanced training on the athletic population and trying to return them to play. And then, of course, there's the different components of it as well.
Yeah, I agree. I think the biggest thing is the patient population and the different types of training you're getting as a whole. So, for example, the on-the-field experience is just a very different component from sports versus orthopedics.
Yeah, there's always the question of return to play and the pressure that those higher level athletes have, or the physical therapist that's involved as well, trying to get them back to play as quickly as possible, but also as safely as possible. Versus in the orthopedic condition or the orthopedic world, you might have that same kind of concern with work comp or other life factors, but it's not always necessarily to the same degree.
Exactly, exactly. I completely agree. So we'll touch base upon that a little bit more specifically later.
Hmm.
The next one is a lot of questions we get are manual-based questions. What type of manual therapy is implemented into an orthopedic residency? Is any manual-based implemented into a sports residency? So, Chris, do you want to go ahead and touch upon that from an orthopedic side?
Well, this is definitely a various answer based on which orthopedic residency you're looking at. And for example, when I was applying to residencies, I focused mainly on ones that had a strong emphasis on it, because some of them don't. And I definitely was interested in ones that had a mentor that was a fellow of manual therapy as well, because I knew that they were going to have advanced training with it. And I think that influenced my residency as far as some of the lesser known research that's out there for trying to facilitate the care of your patients is more utilized in the residency. For example, patients with nerve pain will have a manipulation performed to the thoracic lumbar junction to try and reset the sympathetic nervous system, and it often calms the pain down immediately. And I mean, that's something maybe other residencies are doing that as well, but that's something that I learned as a result of my mentor being from a fellowship of manual therapy. So I mean, there's a big emphasis on mine on manipulation and mobilization. Definitely a smaller part on soft tissue. I believe I've heard that sports residents they have a little more training with that. I may be wrong, but I mean, again, not much taping. Again, sports probably has more in that as well. But yeah, probably mobilization and manipulation are the biggest aspects of it.
So how often would you say you use mobilizations and manipulations in your daily practices based on your population of patients?
Oh, every day, without a doubt.
Okay.
There are definitely some patients that I don't find it necessary. The patient that's hypermobile, there's no way I'm going to do manual therapy to them. Well, I shouldn't say no way. There are instances where I will. But primarily, I mean, we look at the injured joint, the one that's painful, so to speak. But you have to realize, why did it become painful? Well, there might be a hypomobile segment, proximal or distal, that led to that compensatory hypermobility and pain.
Mm-hmm.
And so very often we find something in every patient that we need to use some manual therapy with.
Sure. Kind of following up on that, the soft tissue you mentioned briefly, do you guys have specific training on both your manipulations and mobilizations you spoke of, and as well as any soft tissue techniques, or is that just kind of part of didactic work?
Oh, we definitely have specific training for mobilization and manipulation. With each joint, we cover certain joints that need to be mobilized and manipulation as we make our way through the curriculum of the residency. There is not as much soft tissue, as I mentioned. Now, I've utilized some from outside coursework that I've taken, such as iStim, I think I've heard you talk about you use Graston or Aston in your clinic. Not sure, but it's again varies based on which residency that you're talking about.
Hmm. So one more thing to follow up with that. Give me an example for our viewers on how you get trained in some of your manual therapy techniques. So do you guys sit one-on-one with the patient? Do you practice just on your own with you and your mentor? I know you kind of said each
Yeah.
segment you go through in the curriculum, you kind of touch base on that area. So.
So the way the residency typically works is that for each joint, we have a lecture that typically lasts, I give it two and a half, maybe 3 hours, where we're just sitting in a classroom. It's the other resident, myself, our mentor, and any other faculty members that might be talking. Sometimes we have some students sitting in as well. But then after that, we always go to the lab for maybe 1 to 2 hours to practice the specific manual therapy examination and treatment techniques, just the mentor and then ourselves. And we spend a good amount of time practicing that. And then outside the clinic hours, we get together, practice that sometimes. We have scheduled lab times where we get together, and again, just the mentor and the two residents working on, trying all the different techniques, making sure that they feel equal, trying on different people. Absolutely.
Okay, cool. So I guess from the sports side, a lot of questions that I get is, do you guys do any manual therapy? Isn't that all orthopedic based? Well, I think the biggest thing we have to remember is, orthopedics are the foundation for sports regardless. So yes, of course, manual therapy is emphasized in a sports residency. We do have specific curriculum for it, and we will have mentoring one-on-one with different mentors. We'll have didactic work, and we will also use it for any type of patient population. So, for example, a unique situation that we might use a different type of manual technique would be for a patient that is squatting, and we use some type of cueing manually to see if the source of their pain is biomechanically based. Or we use mobilizations, manipulations, soft tissue. I think we probably use a little bit more soft tissue in the training room, for example. I think that's just the more acute injuries, the more soft tissue injuries with some of the athletes in the training room during season. But there's definitely an emphasis on manual therapy from an overall whole. So because you're not just treating sports and athletes the entire time throughout the sports residency. In the clinic, you're going to see orthopedic type conditions, work comp, Medicare, athletes from high school, college, professional. So you're always going to use manual therapy based on what's necessary for that patient. So therefore, we do get that type of training as well. I think the difference from what I understand is, some of your patients might be, you kind of mentioned with the sympathetic nervous system and different types of manipulations for different types of pains. I think you might see a different type of population, and therefore, at times, it may be more appropriate for you guys to use manual therapy, whereas some of our patients might be more exercise-based, or they might just be more soft tissue-based versus some type of joint mobilization or manipulation. So I think that's what the biggest similarities and differences are. I don't know what you think about that.
I think that I keep going back to this, but it probably varies based on which residency you go to. I know my mentor, again, being a fellow in manual therapy, his theory is more that a lot of soft tissue adhesions or dysfunctions result from joint dysfunction, proximal, distal, whatever. So he sees treating soft tissue as kind of like treating the complaint, not necessarily the cause of the complaint.
Mm-hmm.
And I mean, I'm kind of hesitant to accept that viewpoint, because I think there are definitely instances such as direct trauma to a muscle or something like that soft tissue management needs to become more appropriate. But I keep going back. It comes back to which residency you go to. You're going to get a different viewpoint.
I completely agree with you. I think that
Yeah.
you pretty much nailed it there. And those kind of have questions about, do you do a joint mobilization first or do you do soft tissue restrictions first,
Exactly.
or vice versa? So that's a
Hmm.
whole nother question for a whole nother time.
Yeah.
Let's go through general components as well. That's a question we always get. General components of orthopedic residency.
So, as expected, it varies based on which orthopedic residency you go
Of
to.
course.
But in general, you're going to have uh, clinical hours, which can vary from anywhere but to 20 hours a week to full caseload, 40 hours a week. And that's going to be different at each one.
Hmm.
You're going to have a lot of outside reading. I know mine incorporates Shirley Sauerman's texts, the OCS monographs that are published by the orthopedic session of the ABTA, and then lectures from 1 to 2 different faculty members for each joint. So that's the didactic portion. I mean, you help out at events around for mine, the Scottsdale area, which could be at like half marathons, just community talks at a high school to promote the profession. Next week, I'm helping out at a cervical course, just teaching different manual therapy, assessment, and treatment techniques. Um, you might have a student. Some of them have MD rounds and surgical observation, uh, and some of them have research as well. I know mine doesn't, but you present case studies. Absolutely, there's usually something where you have to show what you were doing during the residency, some sort of presentation component as well.
Hmm. And probably to add to yours, I know USC's ortho residency does involve teaching and a research
Yeah.
component, kind of like you mentioned.
Hmm.
So it does depend on every single residency, and that's what we both tell our viewers and all the residency candidates that are asking these questions. It really depends. So it's what you're looking for,
That's
and you need
exactly
to
it.
be the director of the program to decide on what you're looking for. So from a sports aspect, they have the certain requirements from the DSP, just like an orthopedic residency. But I think the main components are, there has to be some type of on-field hours. It does not matter typically what level that's at. Often it's at the high school level. Sometimes it could be in the college level, and sometimes it could be at the professional level. So, again, that's going to differ on depending on what residency you're in. Mine does a little bit of everything. So that's what I was looking for, was a little bit of everything at every level. The other component is you do have to have clinical practice. Sports, I think, has just a little bit less clinical practice because we are in the training room and we are covering games and practices. So I think sports as a whole typically has a little bit less time in the clinic, but again, that's going to depend on each residency. The other thing I think is you mentioned MD rounds, you mentioned research, you mentioned didactic work. Everyone's going to be a little different. It's going to be their philosophies and their faculty. At USC for sports, they do a lot with the orthopedic residency, so we get the USC sports residents gets the ortho monographs as well. We do all the literature reviews with the ortho residents. So we do a lot of orthopedic stuff as well, which is a little different from some of the other ones. We do MD rounds. We do surgical observations and research if you choose to. But we don't really teach too much. So I think orthopedic residents, from what I hear, typically have a little bit more abilities to teach in practices and in universities, whereas the sports don't really. I don't think there's really a time frame for them to fit that into their schedules. Uh, that being said, we will teach one class in July, but it depends on what residency you're in. Some of them actually do emphasize teaching.
Yeah,
Another,
and I think it goes back to what you want to look at the residency that goes after what you're interested in. For me, I was more interested in improving my clinical skills, so I chose one that had 40-hour work weeks. Class and didactic stuff was typically done outside of those hours. I wanted to practice everything I learned as much as possible. Now, as a result of that, there was less time. There is some teaching. I mean, we do get a student for 2 months that we're a clinical instructor for, but it's not like you're teaching in a classroom at mine. I don't have any research other than a couple case studies that I did. It's definitely you wanna know what you're interested in and try and go after those types of residencies.
Exactly. I completely agree.
Yeah.
So let's go to a more specific question on patient population. We
Mhm.
touched on this earlier, but I think this is one of the biggest questions you get is, does orthopedic just see, work comp Medicare or just ortho? Do they see any type of athlete? Does sports see just athletes, or is it everything? What are you getting? So from ortho's perspective, want to go ahead and touch base on that?
Yeah, you definitely see some athletes, but absolutely not the same percentage as those in a sports residency. And you have to go back to or residency location as well. I mean,
Mhm.
being in the Scottsdale area, there is a larger Medicare base, but I mean, sought this residency out specifically because it had such a high percentage of non-surgical patients.
Mhm.
And I mean, you're going to get a variety based on which one you're looking at. You get a lot of work comp. I mean, being at a hospital system for me, someone gets injured at work, they're coming right over, and I get to evaluate them and start treating them immediately.
Mhm.
Um, you might get a little higher percentage of that orthopedic residency-wise compared to sports. I may be wrong, but probably a larger dose of Medicare compared to sports residencies, and again, a much smaller percentage of athletes.
Yeah, no, I think you said it well again. Depending on where your clinic is, depending on where you are in the country, is going to make a huge
Mhm.
difference. If there's some sports residencies that are based out of a clinic, a private clinic, there's some that are based out of a university setting.
Mhm.
There's some that are based out of a major company, like a NovaCare, for example. Um, so it depends. So I think as a whole, depending on where you're at, you're going to see a different population. Now, what is required for sports is you have to see a minimum of 40% some type of sporting population, but that could be recreational athletes. That could be
Mhm.
your weekend warriors. So it's kind of a gray line for what is considered an athlete. But I think as a whole, you're going to see anything from the recreational athlete to the professional athlete, and anything in between. It really depends on where you're at.
Yeah, I think there's kind of a guideline for what orthopedic residencies should have their residents expect as far as patient population, but in regards to joint specificity. For example, I believe the expectation for ortho residencies is that you'll see maybe one or two TMJ patients during that year. Same thing with hand. You're going to have those joints that are less specific, but they want to make sure that you're seeing the appropriate percentage that wise, but not necessarily athlete versus work comp or anything like that.
hmm And just to clarify, you will see work comp, you will see general ortho, you will see Medicare from time to time in a sports residency,
Hmm.
unless you're just at a university or um, or like a professional only, which I don't think there's just any professionals, but I think there's plenty of university ones. So USC has like one site that's just at USC's athletic medicine department. So you see just college age students, student athletes. But I think in general, you're not going to have that. In general, you're going to have some type of clinic base. So you will see other type of patients. They just might funnel you a little bit different depending on the way the clinic's set up. So didactic work was the other thing. What type of didactic work does ortho get versus sports?
Well, I kind of touched on this already in
Mm-hmm.
that my residency typically has you have your readings to do beforehand, before your lecture each time, and that includes all the monographs for each joint um, that the orthopedic APTA section puts out, and that's typically the preparation for the OCS. You have the Shirley Sauerman text for each joint. That's movement impairment syndromes. And then you have the lecture from the mentor that is the fellow manual therapy. So you get kind of that manual perspective for your lecture, and then you also have another faculty member typically that gives kind of a mix of the OCS Sauerman application to each joint. It's not necessarily anything defined, but that's the general aspect of it. You come in, you have a lecture, as I said, for a few hours, followed by lab for a couple hours. On top of that, we have additional readings for medications, imaging, clinical reasoning, research, but that's the kind of basis for it, I would say.
Sure. So from my perspective, what I've had personally, and this is going to differentiate again with any clinic or residency you're in, we've had orthopedic seminar courses that were 8 days long apiece. We had 2 of them for like 16 days with the other ortho residents. We had 2 4-day sports courses, which is just based on sports biomechanics, return to play criteria, and a lot of on-the-field criteria. So that's the biggest thing that I think some of the residency candidates don't understand, is that for sports you have a lot of on-field return to play criteria, a lot of like wound care type things, taping, casting, concussion stuff. So there's quite a bit of that in the sports medicine in the sports medicine world, and that we kind of get tested over for the SCS. So there's a lot of that going on. And it's not just agility training and sports biomechanics and how you pitch correctly and stuff like that. That's included, but we got to remember that the main focus is around the on-the-field experience as well. So there's a lot of that emergency care going on.
I think you actually kind of unintentionally mentioned some of a different perspective of this, is that sequencing of that didactic work. I mean, I think you told me that USC, the main component of it was done at the beginning of the year, correct? Or at least
Yes.
A lot of it was. Versus me, I had a lecture probably every 1 or 2 weeks for each joint, and they kind of tried to sequence it as far as the percentage of patients joint-wise that you would see. So we started with SI, lumbar spine, kind of worked our way from there. The last thing we covered was the hand, because having hand therapists at our clinic, that's kind of the least likely thing that we would see.
Sure, whereas from our perspective, we needed to go over all the on-field emergency care right away, because you jump right into football in the fall, and then you supplement the rest of the year with literature reviews every week to go over joint by joint. So depends on what the setup is, but I think it's important to go over some type of emergency care in the beginning before you get on the field. So
yeah, absolutely.
All right, so let's wrap this up as a whole. What do we feel like is the biggest similarities and biggest differences from kind of just this chat we've gone through right now?
And I think that the biggest similarity is that both of them have orthopedic as a base.
Mm-hmm.
And I think that kind of ties into the biggest difference in that how you apply it and to whom you apply it, that patient population. I mean, with that orthopedic base, we might kind of approach each patient differently. I myself might view, maybe this is kind of driven from the spine, versus you kind of are focusing on that extremity, as maybe it's an overuse injury, you need to work on the biomechanics of that. I'd say that's the biggest focus. Less time more time in the clinic for ortho, less for sports, but you're kind of doing more of that athletic base to it, where again it comes back to what are you interested in, and that's what you need to focus on.
Sure. I agree. I think the biggest similarity is there is ortho no matter what. That's the base for sports. You can't not know ortho to treat sports, because they are orthopedic patients. And they might start at the same level as any other patient. They might be super weak and have to start with something like a clamp. You're not just jumping into, again, agility training, jump training, all those things. You might be building them up for almost an even longer time with basic exercises because of some deficits or weaknesses they have, and then get into the terminal phases and whatnot. So I think maybe a difference would be those terminal phases of rehab. There might be a little bit more advanced exercises depending on what type of patient you have, kind of how you touched upon that earlier. But let's be clear that an ortho resident can definitely treat an athlete, because again, ortho is the foundation. The differences, I think, are just the additional training and the understanding of the athlete as a whole in the sports medicine world. So understanding how to understanding that you need to know about his or her nutrition, their strength and conditioning, their athletic training at the high school, college, professional level, what the MDs are doing with their agents. That's the biggest thing. Again, if you run into agents, you have to understand how to communicate with them too. Coaches, that's a whole nother animal. if you're at the high school level, talking with parents, but probably get a little bit of that as well. So
I think.
yeah.
Go ahead.
No, I'm done. You're good.
Okay. Some of those orthopedic residencies do have a sports component, but that's just it. It's a component. Versus with the sports residency, you're doing it all year long, and it's like everything you're learning translates back to sports. How does it apply to the patient that needs to get back to play? All that sort of stuff.
Yeah. No, I completely agree. So, I think we can both agree that ortho can treat sports, sports can treat ortho, but there's always going to be a little bit of differences, and that's the purposes of the subspecialties, and depending on where you're at with what residency is going to be a different emphasis on different components.
Yeah. If you want to mainly treat athletes, do a sports residency. You can do an ortho residency and still treat athletes, but if you only want to treat athletes, you got to do sports.
Yeah. So if you guys have any more questions or comments, feel free to email us at thestudentphysicaltherapist@gmail.com, or Chris and myself would be more than happy to answer any additional questions. Thanks for joining, Chris.
Thank you.